that there's high resistance flow in bilateral uterine arteries at 32 weeks gestation.
For a normal growing fetus, we do not look at the uterine artery Doppler. But if the baby's weight is less than the 10th centile, it is useful to look at the uterine artery Doppler because it acts as a predictor for abnormal brain Dopplers developing later on in the pregnancy. So if you have a small baby less than the 10th centile at 32 weeks, and if the uterine artery PI is high, we would classify it as late onset FGR and put that baby on late onset FGR protocol. But the Delphi consensus does not include uterine artery in the third trimester late onset FGR, but we do use it because that is a sensible thing to do, and a lot of studies have shown that it works, but not in a normal growing fetus. In a normal growing fetus, the uterine artery Doppler does not have any role.
So you mean to say that if there is evidence of FGR, even at the late pregnancy and the late trimesters, you would like to have the uterine artery Doppler done?
Yes, there it works as a diagnostic marker. Uterine artery in the first trimester is a screening tool to tell us whether the mother will develop preeclampsia later on, or whether there is a possibility of FGR later on. But in the third trimester, it works as a diagnostic marker. You have a baby less than the 10th centile. We are looking what is the cause for the smallness. So we look at the maternal supply also, and if the maternal supply is bad, we find a cause for abnormal smallness, and we classify it as late onset FGR, but not in a baby that's above the 10th centile.
If you find it, any additional treatment modality for that?
Surveillance, only surveillance. We just put this baby on surveillance, which otherwise would not require a high-risk surveillance that an FGR baby would require.
You won't put them on aspirin or
Absolutely not. Absolutely not.
So the next question is again on fetal Doppler. Patient having either a normal growth or a fetal growth restriction with normal umbilical artery, but having an abnormal MCA. Is it significant? When to repeat the Doppler, at 34 and 36?
Okay, the MCA in a normal growing baby, we should understand, has got a lot of inter and intra-observer variability. And also the fetal state can affect the MCA Doppler. Therefore, MCA Doppler does not work or function as a standalone parameter like the umbilical artery. The umbilical artery can work as a standalone parameter because it looks at the placenta, and we know when the placenta is bad, you're going to get a bad umbilical artery. But the MCA can show signs of increased diastolic flow or decreased diastolic flow depending upon fetal behavioral states, depending upon where the head is, whether it's deep down within the pelvis, whether the mother has a very thick abdomen, you have to press the probe to actually get the middle cervical artery. All these things are going to affect the MCA. And so my advice would be to not look at the MCA or the CPR in a baby that is growing very well. Otherwise, you'll just land up in trouble. If a baby is less than the 10th centile, then the story changes. We need to look at the MCA and the CPR. And if we find an abnormal finding, repeat the ultrasound again and see if the findings that you got before were reproducible. And if they were reproducible, then classify this baby as FGR.
So with such a finding, when do you like to terminate? The MCA is dilated, the umbilical is normal.
I am assuming that this is a small baby.
Small baby.
So if this is a small baby with an abnormal MCA, that is a dilated MCA, which means that this baby may have hypoxia, I would put this baby on increased surveillance, look at the CTG, look at the biophysical profile, and push this baby till 37 weeks. And once it crosses 37 weeks, I would be happy to deliver this baby, but not before 37.
Is there a role for low molecular weight heparin in case of early onset FGR, even if the apply is negative or normal?
If you are making a diagnosis of early onset growth restriction, if you have made that diagnosis, then the chance of low molecular weight heparin acting is completely gone. There is no point. The advantage is always to start it before or early, and whether we should start it for an APLA negative or an SLE negative patient is quite debatable, because there is this entity that is seronegative APLA. So if you have a history that tells you that definitely this baby could be APLA, so for example, you have 2 pregnancies that have had severe preeclampsia, if you had to go in for previous preterm delivery for FGR on more than one occasion, then, and if your lab parameters are turning out to be negative, I would still put this patient on low molecular weight heparin because I think it might work. But once FGR has set in, you have that situation already there because the placenta has already been damaged, low molecular weight heparin will not
So
help.
the management is mainly monitoring and monitoring.
There is no other management in FGR.
Okay. Role for sildenafil?
No, the sildenafil did come in as an entity before, but then there was this trial, I think it's a Strider trial, which looked at sildenafil and found that it was not effective.
What about amino acid infusion?
Absolutely not. Absolutely not. See, again, the point here is the placenta is the supply organ. So whatever you pump into the placenta, if it is not able to be extracted by the fetus, it doesn't matter. So it's not nutritional deficiency which is causing a smallness in size. But having said that, a recent study has shown that in the developing world, we do find small babies because of nutritional deficiency. So if you're finding that the mother is poorly nourished and everything else is fine, this is actually working in very underdeveloped sections of the society where you have a mother that's hardly eating. In those conditions, having good nutrition would help rather than having supplements. But that is the very, very small minority. And I don't think that works in our setup. In our setup, when you have a bad placenta, it is the bad placenta, and please don't pump in them with proteins or alaminosin infusions.
Many more questions in FGR. A pregnancy at 26 weeks showing having a diminished fetal movements and shows placental calcification as early as 26 weeks. How do you go about managing that patient?
Now, placental morphology was used before the era of Doppler. Now we have a more objective method of assessing the placental function. So we do not look at how the placenta looks subjectively. So we have stopped grading placenta. That's gone. Now, next thing is about fetal movements. I'm worried about fetal movements in the third trimester rather than in the second trimester, because the mother might not be able to perceive all the movements properly, and it's not a very good indicator. But in the third trimester, the ball game totally changes, especially in a scenario where there is fetal growth restriction. We should pay attention to the mother, and if she says that there is decreased fetal movements, I would be more worried about it.
Okay, just two more questions on FGR. In case of FGR anomaly, in case of FGR in ultrasound, there is FGR in ultrasound, and is there a role for torch screening? And what to do if in case of IgG positivity?
Now, we look for infections only if we have a small baby with good Leica, with good Doppler, especially early onset FGR. Not late onset. So if you have early onset FGR, there's a baby that is extremely small with good Dopplers, good Leica, then we can investigate for infections, aneuploidy and things like that. Now, infection, again, it's a whole different lecture altogether on what to do if it is IgG positive. Again, you have to confirm whether it is maternal infection and then go in for an amniocentesis PCR and all those things. I don't think we have time for that. But if you do find or do suspect maternal infection in a setting of a small baby, go in and do an amniocentesis and PCR and confirm whether there is fetal infection or not. Pardon?
Bijoy, can I just add that?
Yes, if you have an IgG that is positive, the first thing that we do is we do an avidity testing to see if it is recent or old. But you should understand that high avidity means an infection that has happened 3 months ago. So if you have a baby that is growth restricting at 28 weeks, 3 months ago is still within the pregnancy. So what do you do in those cases? You do a repeat testing and see for the titers of IgG. You do a repeat testing after 2 weeks, and if you see that the titers are increasing by 4-fold, then you know you're looking at actual infection and not an old infection.
Yes, Uma.
The point is also at 28 weeks by screening for infection, how much are we going to gain is one thing. And two, I would like to use this point to emphasize that we should be doing serology, especially for rubella, at booking. In many places still it's not done at booking, and then later at 26 or 28 weeks an IgG is done, and then a dilemma is created. Because unlike in many parts of the world where they store sera and you can go back and check, we don't have that luxury here. So at booking, at least rubella, it would be helpful to have a serology documented.
Uma, if the serology is negative, rubella negative, any special advice?
If the rubella IgG is negative at booking, in our practice, we make a note at the back of the card so that after delivery, we are advised and vaccination is given. Yes.
Just with the suspicion of preterm labor, once Maxelf has been given, do you want to repeat a second time before, if we want to take out the baby early?
As far as steroids and Maxelf is not about preterm, I'm talking about FGR setting.
FGR.
If you are deciding to give steroids and Maxelf, it is once the delivery criteria are met. I do not believe in giving prophylactic steroids in FGR thinking that the baby will deliver in a week or 10 days. So if the delivery criteria are met, then we give steroids in Maxelf. The only difference would be when there is preeclampsia. When there is preeclampsia, then I'm not sure how my Doppler parameters are going to change, and therefore that is probably the only condition where I'll give prophylactic steroids in a setting of FGR or MaxSelf. But otherwise, in a setting where there is no preeclampsia and the baby is just small, I will wait for the delivery criteria to be hit before giving steroids. And within 1 week. And I will never give steroids after 34 weeks, because after 34 weeks, there is no evidence to tell us that steroids are going to be effective. Actually, there is enough evidence to tell that it could be probably harmful. So I would not give steroids after 34. It's only for the early onset varieties or the ones that come before 34 that we give steroids.
Many of us are giving even beyond 34 weeks, up to 36 weeks. Would you strongly recommend that we stop it?
See, the only theoretical advantage of giving steroids after 34 weeks is to avoid transient tachypnea of newborn. But there is a lot of information coming from the pediatric neonatology group, which tells us that it could affect the myelination of these small fetuses. And therefore, till we have enough evidence to tell that the steroids that we give after 34 weeks is not going to affect the myelination or going to affect the long-term outcomes of these fetuses, I think we shouldn't be giving steroids after 34 weeks just to prevent transient tachypnea of newborn.
One more question.
Yes. But after 34 weeks, its evidence is very less actually on whether it helps or not. Yes.
About MaxSelf, 32 weeks, 33
No,
weeks,
32.
weeks.
32. We don't give beyond that.
So let's be very clear about it. There is always ambiguity about these two things. When to stop giving MaxSelf for neuroprotection and when to stop giving steroids. And 34 for the second and 32 for the first. That is what you would recommend. Okay, thank you. Thank you, Deepthi.
Thank you, sir. Thank you, Suja madam. Now,
GDM diabetes.
our discussion is, we will have whatever doubts are left behind, we will do it in the open house time. We will have it during the open house.
For lack of time, the remaining discussions can be had during the lunch
Open house
break.
we'll take during open house.
Sorry for the time constraints.
Dear delegates, we have exactly 2 more sessions to go before lunch. That means 20 minutes each. And the first is on preterm labor and PROM. Dr. Neeta George from Jubilee Mission Medical College is the lead discussant. Along with that, Dr. Sushila Rani from Bangalore, Dr. Ravichandran from Malaysia, and Dr. Bindu Menon, a professor from Jubilee Mission Medical College.